Hi, everyone. I'm so excited today to have Eileen Davidson, chronic Eileen, not for the first time on the Arthritis Life podcast. Welcome.
Hi, thank you for having me again. It's always a pleasure to be here. And yeah, we have a lot to say. So I think it's appropriate that we keep these
And
conversations going.
today it's going to be a little different than my typical episodes on the Arthritis Life podcast because we have a very specific goal today, which is to review a talk that we gave with a multidisciplinary panel last November 2024 at the American College of Rheumatology's annual Convergence Conference. And the talk was called It's Not Just Joint Pain. Can you tell me a little bit, Eileen, um, what inspired you to create this session?
Well, it is a little bit of a story because it goes back a few years. I have been participating in research since 2018, particularly with the Arthritis Research Canada Patient Advisory Board. And so I've had the opportunity to attend a number of the rheumatology conferences, not just the American College of Rheumatology, but also through another organization and through Arthritis Research Canada. I have attended the Canadian and the European one, either online and in person. So I felt like have started to sort of see trends over the years where research is focused and where it isn't focused. And as a patient living with a rheumatic disease, where I personally would like to see some more research on. And then not just that, as a patient advocate, unlike you, somebody who runs support group and who does, lots of content creation, we see trends in what other patients are saying because they're very similar to what we're saying. And, when I write an article on fatigue, it's always the top one. When I write it or talk about brain fog, people are just like, I didn't realize this is even part of the condition. And you start to realize you're hearing these things more and more. So then you realize there is a huge gap in not just the research, but the knowledge, understanding, and resources for certain areas of living with a rheumatic disease. And also living with a rheumatic disease, we're all going to say is a lot more than just joint pain. So highlighting those symptoms that are extremely debilitating or hard to deal with every day. Um, and then what might help them. So I had been invited to speak at ACR before on multiple different things with researchers. And I like to set little goals for myself and just try and do things because that was something that I actually used to really struggle with living with mental health throughout like my teens and my 20s. I didn't really set goals or do things, to, I guess, better myself or learn more. So I was like, I'm going to learn to submit a session and I'm going to submit a session on what I think is missing. And I'm going to invite some really cool people that I know to be on the session because they have a lot to say about the topics that I want to talk about. And so I created It's Not Just Joint Pain, Demystifying Difficult Symptoms of Rheumatic Diseases Often Neglected, for myself and also for my community.
I'm just before we go into today we're going to be covering like our biggest takeaways from the 5 areas that we discussed, which were, sleep with rheumatic disease, fatigue and rheumatic disease, cognitive dysfunction, mental health, and then the role of nutrition. And we kind of interwove comorbidities throughout that as well, like coping with multiple comorbidities. And before we do that, I'm just going to give credit to the other speakers. It was just I didn't even try to get all of us together, honestly, for a podcast because I just know our schedules are too variable. So I thought maybe Eileen and I will debrief. But we had Dr. Ayman Asghari, who's a rheumatologist in England, and Dr. Susan Bartlett, a clinical psychologist and professor of medicine at McGill University and adjunct at Johns Hopkins. She's a psychologist. And then me, and then Christina Montoya, who's a registered dietitian in Colombia and Canada, and then Dr. Daniel Woodby, who is an assistant professor in the Department of Physical Medicine and Rehab at University of Michigan, and he has his background is in being a physical therapist as well, and he's really a sleep specialist. So you assembled like a superhero team of experts to really delve into these what's called in the OT world, occupational therapy, we call them extra articular symptoms, or things that don't relate to the joints but are related to the disease. So let's start with the one that people would mention is difficult for them most often, is fatigue. So we delved into the science of what is the relationship between rheumatic disease and fatigue. Unfortunately, even today in the year 2024, there are still rheumatologists who will say, oh, your fatigue isn't related to your RA or your AS, even though there's this wealth of evidence that it can be. So we outlined a bunch of research and also talked about the impact of fatigue on quality of life, and also what were the effective treatments from our different perspectives. So what were some of your takeaways from the fatigue section of this talk?
To be honest, my main takeaway with fatigue and also cognitive dysfunction was mostly that it really highlighted a lack of research and treatments and understanding and knowledge and resources when it comes to these. Just from going through making the resource guide and then also pulling the information that people do know, because there's still so much that needs to be known, and the treatments are difficult because of the condition or the symptoms themselves. It's no surprise to me that exercise was talked about first and foremost when it comes to alleviating or helping these symptoms. But then it also reminds me how hard exercise is to conduct in the first place when you have fatigue or cognitive dysfunction. So I think my biggest takeaway was, wow, we need to keep pushing for more resources, more information, more support on especially fatigue and cognitive dysfunction. But then it also reminded me how powerful exercise is, and not just for just fatigue, but it was the one thing that we could do that would help all of the symptoms we were talking about. And like just how important it was. And then also listening to like your testimonial about how much strength training helped you previously, how much exercise really helped me, but it's so hard to find the consistencies. So especially when dealing with new diagnosis of comorbidities and how that affects my fatigue. So how my sleep has been affected and everything too. But yeah, I think my biggest takeaway was definitely exercise is always the number one recommended treatment other than our actual medications. And the huge lack in or gaps in around fatigue and cognitive dysfunction. And, just hoping that the session that we held there, flagged that to some researchers or clinicians. And then one thing that I thought was really important to bring up was that one of the researchers had told me that fatigue had been mentioned at OMERAC around 20 or so years ago, but it wasn't until 2023 that the first guidelines anywhere came out on rheumatic diseases. So it took like a good 20 years. So they have been doing lots of stuff in patient identified issues for a while. And Susan Bartlett, who was on our panel, she is an arthritis researcher from Arthritis Research Canada that I have actually worked with a couple times on studies involving mental health and arthritis. And she has also spoken a lot about fatigue, how much, that is a call for anything for patients, really. And she was the one who told me about how OMERAC identified that 20 so years ago, but it has taken this long. And that I have heard before, research can take up to 17 years before it actually makes clinical practice. Yeah, so in a sense, also like going back to your first question, why did I do this? To speed things up a little bit, maybe. Um, Flag how important this is to, patients. Um, feel like I want to make a difference somehow.
And you are definitely making a difference. And, just a couple of things I would add from my takeaways. Definitely that it's, you know, kind of incredible that it took until 2023 for any rheumatology association to come out with an evidence-based guideline for fatigue in rheumatic and musculoskeletal diseases, but it does exist. And I'm going to link it in the show notes. It's also linked in your resource guide. When we say resource guide, that's like a master list of all the resources relevant to this presentation that Eileen put together. That's super, super helpful. And I just wanted to share a couple, I think when you hear all the time, if you have rheumatoid arthritis, you should exercise. Exercise is good. And it's hard to, it's hard to actually get yourself to put it into practice because you just get irritated hearing it all the time. And also you're like, how helpful could it really be? But I think when you drill down into the specifics of some of these studies, it helps you, for me at least, it helps me feel more like, okay, wow, this is a big deal. One is a randomized control study on the effect of exercise on sleep and fatigue in rheumatoid arthritis. And they had one group of people with RA randomly assigned to not exercise and the other group assigned to exercise. And they not only saw significant improvements in pain and fatigue, but it also improved sleep quality and stiffness and health HAQ scores, which is like a general quality of life, like health related quality of life, which is amazing. And then another one did a randomized control trial of a patient specific exercise program. It's important to note this was people who were given the guidance by like a trained physical therapist. The people assigned to the exercise intervention not only had better fatigue scores, they had significant improvements in C-reactive protein levels. So it's actually affecting the inflammation itself. So
Yes.
yeah, and I think so that's the why. It's the how that's hard as a patient. How I personally have found that the two things that really move the needle for me in terms of actually implementing exercise and being consistent with it are having some sort of external accountability, whether that's a group or someone I've signed up for personal training sessions with.
Yeah. I realize that's what I'm missing and I need to find. There's actually one thing I'm going to quickly say about the CRP thing before you go into that, is that research has actually proven that exercise helps our medications work better. So it's no wonder our CRP would go down when we start exercising because it's actually helping our medications work better.
Yeah, and I think, the biggest thing is just figuring out what's going to work for you. I mean, the only other thing that works for me is doing it first thing in the morning, or not like first, like I'm one of those people that has to eat first thing. But doing it in the morning before I can get distracted by the rest of the day, that really helps me. So you asked the question to the panel, how does your profession research or address fatigue? And managing fatigue along with managing pain is part of what is called self-management, which is definitely recommended for all chronic illnesses. Self-management is simply learning the tools to manage your symptoms and your condition on a daily basis. So OTs, occupational therapists, can also teach you not only these things like exercise, which can improve your fatigue levels, but also what we call compensatory tools or workarounds, like learning energy conservation, strategies, ways to save energy throughout the day so that you can accommodate for maybe any lingering fatigue. So it's not necessarily that you're going to get your fatigue down to zero, right? You can move it down by exercise from its high point, but then the remainder of it, you might have to accommodate for it. So,
yeah. Just the highlighting like how important that exercise was, and also how we picked these symptoms also because they all kind of tie into each other. So when you have bad sleep, you have more fatigue. When you have more fatigue, you have more cognitive dysfunction. And then when you have more cognitive dysfunction and fatigue, you have worse mental health. And it all just kind of goes around, and how that I think like what you just spoke about, how occupational therapists can help you with fatigue and energy conservation, but OT can help you with everything that is talked about on through this panel discussion. And that is why I definitely wanted an occupational therapist to be on the panel, because I do 100% consider them the unsung hero of any rheumatic condition. And yeah, I would say I've kind of already talked a little bit about my takeaway with cognitive dysfunction, and tying in with fatigue. But I guess as we move into cognitive dysfunction, my biggest takeaway was when Daniel Wibley told me that cognitive dysfunction is actually separate from fatigue. They're not the same thing. So I'm like, but I have cognitive dysfunction when I'm most fatigued. Like, so I would associate them being connected. I would have think that my brain is fatigued, so I'm having cognitive dysfunction. But he would be the better person to explain, what exactly is cognitive dysfunction. It's not really that well known. And like when we talk about this resource guide, we'll dial back a tiny little bit. I'll explain what the resource guide is we went on the internet and found as many of the resources we could on fatigue, cognitive dysfunction, sleep, exercise, whatnot. And if it was either involving like a clinician of some kind or an organization, we put them down on my website. And so it's a ton of information for patients and clinicians to be able to go to when they're feeling stumped on these particular symptoms. However, when we were searching the internet for cognitive dysfunction resources and references and everything, there's such a tiny, tiny amount, which is a huge gap.
Yeah. Yeah. They're actually one of the few articles I did find is called Cognitive Implications of Rheumatoid Arthritis, a Call for Comprehensive Care and Research Focus. That's from 2023. So 1 year ago. So
Yeah.
they're saying a call to action, like on the provider side, to figure out like, hey, we need to address this in our patients. So that is step one, right? Identifying the problem and clarifying that it's related to the condition. This was in the Journal of Immunity, Inflammation, and Disease, interestingly. So it's not a rheumatology specific journal, but obviously overlaps with rheumatology. And sorry, I didn't mean to steal your train of thought. I just thought that was you were presenting the call to action as well. And it's
bringing up that study because that is literally the only study that we could find on cognitive dysfunction and rheumatoid arthritis at the time. Mind you, we didn't do that as an extensive deep dive as like a researcher could do, because they can go through a whole different kind of data bank. But that was the only resource or reference that we could find on it. And there was only one resource other than my brain fog essays.
I found one and I was like, oh, there's another one. And then I realized it was actually an abstract being presented at the conference, like the
Yep.
day after our presentation.
Yep.
So it was like theirs was neuropsychological evaluation of cognitive impairment in patients with rheumatic diseases in general. So again, it's like this is like almost like the final frontier, right, of addressing these extra-articular symptoms. I didn't know for so many years that any sort of brain fog that I was having was related to my rheumatoid arthritis. And I think you're right, like Daniel said, it's not that it tracks perfectly with fatigue or overall disease activity. It's still unclear the mechanism of how this is happening. I think one of the most important takeaways for me was remembering when it comes to any of these, but especially cognition, is that the SPACE acronym, spaced symptoms like sleep, S is sleep, P is pain, A is affect or emotions, C is cognition, and E is energy or fatigue. This was, Dr. Afton Hesse and the other researchers at University of Michigan, proposed this acronym to say, based on research, that all of these 5 variables are very interrelated. So if you get poor sleep, you're going to have worse pain, worse mental health, worse cognitive abilities, worse energy. But the good news is if you have better sleep, it bleeds over into improvements in the other areas. So I always say that when I'm doing my Room to Thrive groups or just doing any presentations, I always say that that's a good news, bad news situation, right? Because the good news is that they're interrelated, and that if you can improve, if one of them's poor, you can try to improve it by improving a different one. But the bad news is that something bad in one area, like let's say your fatigue's really bad that day, can lead to dysfunction or bad stuff in all the other areas. So
Yeah.
I think just remembering that as a construct has been so helpful for me. And what Dr. Afton Hassett says is, if you're having a hard time, let's say with your pain, think about whether, or let's say affect emotions, think about whether you can come at it sideways. That's what she called it, like where you, instead of just thinking, what are my mental health tools or what are my pain tools, can you turn up the dial or improve one of the other symptoms? Like, can you improve your fatigue by exercising, or can you improve your sleep that night? Maybe that will help address whatever's going on with you. So I think that's a huge just overall takeaway for me, is the interconnectedness of everything. These are somewhat different whack-a-moles if you're playing the game whack-a-mole, but they're also overlapping quite a bit. They're kind of tangentially related. I will say that in that 2024 abstract from the conference, some level of cognitive dysfunction was found in 86% of patients with rheumatoid arthritis. This is the study by Dr. Gabriela Inés Madrid Lopez and Maria
Yeah.
Corral Trujillo. So this is from the University of
It's in Mexico, and there is something that I've noticed because I went through so many of the abstracts, and I mean many, literally all of them. One pages,
you get a badge for that.
I know my back really hurts. I can't wait for my RMT. But anyways, one thing I noticed when I was polling all my favorites, or the ones that I would actually read because I didn't read the ones that were way too scientific, I noticed how often Mexico kept popping up for really interesting studies. Like they had one about premenstrual dysphoric disorder. They also had, I think, a perimenopause one, and then they had the cognitive dysfunction one. There were some others. They were all just really good, interesting studies that were really interesting to me as a patient living with it. And I found like, wow, this needs to be talked about more. So University of Mexico, I believe it is. I noticed that they had a lot of really cool studies this year. So I think Mexico is a place to look out for. And I wonder how they identified these studies. Like, do they involve patients? Is it like a patient advisory board that they have? Or it could also be that there's researchers living with the condition. So, so many questions.
Yeah, I found one very patient-centered research poster from Colombia, which was about shared decision making.
I remember that one.
Yeah. But there was a study in 2020 that showed the benefits of exercise in patients with rheumatoid arthritis, a randomized control trial. Again, a different control trial. This one also showed a positive impact of exercise on cognitive function in rheumatoid arthritis. So again, just underscoring, you might get annoyed at hearing people say exercise all the time for rheumatoid arthritis, but it's not just about developing muscles to support your joints. It can be to improve your cognition and your fatigue levels. And these things are what get me out of bed sometimes to get onto the exercise bike or into the strength training. But it's amazing how much you can know this is important when still not do it sometimes, just because humans are complicated, right?
Absolutely. And it goes back to talking about SPACE acronym again. Like an area that I want to fix it or work on is my sleep, because in the winter I go to bed too early. So my sleep has been good, but the problem is I'm waking up at 1 or 2 o'clock in the morning because I'm going to bed too early. So that's creating more fatigue throughout the day for me. And then when I think about exercise, it's also because this is just being somebody who lives with a condition, knowing that when you start something or you do something, you're gonna get benefits in one area and then pay for it in the other. So One thing I've noticed when I start to exercise, my cognitive dysfunction can actually get worse because of post-exterior malaise. And that is common with fibromyalgia.
I always thought it was maybe that I'm overdoing it. I don't have fibro, but I do get my fatigue can get worse sometimes if I've
Yeah, it
exercised.
does. It gets worse before it gets better.
Yeah, yeah.
So it's not like we can just okay, we're gonna start exercising because if you're like me, busy single mom trying to work, and then you're like, okay, I'm gonna exercise every day, but then I'm gonna miss a million meetings. So it's like you actually have to plan do these things. And that's where you're going back to the energy conservation and OT and all that, which can really help. And then just like watching them going through resources and learning those little steps that you can take so that you can improve fatigue or cognitive dysfunction, can get moving easier, or switch restrictions or things that you need to go through.
Yeah, and just like with fatigue, we have compensatory measures that are not about improving the underlying variable, but about accommodating for it or working around it. We have those for cognition too, right? So if your working memory is the issue, you're forgetting things, external reminders, just the same things we would do with somebody with a brain injury, to be honest, having
Yeah.
external supports and task simplification or delegating things, chunking tasks out so that you're not getting too overwhelmed. Those are all things that can be worked on. And I know they're actually being done often now in post-COVID recovery or people who have long COVID, because brain fog, for better or for worse, there is more research out there on cognitive dysfunction and brain fog because of long COVID, because that's a pretty big symptom. Fatigue and brain fog are big symptoms of that. So the last three, I'm trying to be mindful of time because we've got about 20 minutes, are mental health, sleep, and nutrition. So now this, we don't have enough time to cover all these in the most depth, but I know you and I are both really passionate about discussing, the role of mental health in rheumatic disease. What were some of your takeaways from that section?
I think one of the biggest takeaways from the mental health section was how necessary it is in the beginning of a diagnosis, not just if the patient has a diagnosis of anxiety or depression, but because of the grief process when being diagnosed with a rheumatic disease, all the changes, whatnot. And shockingly to me, I find it quite interesting how there are people with rheumatoid arthritis who do not have depression. Um, that shocks me more than the fact that a lot do. Um, I want to know what's going on with those people that don't have it.
Maybe the ones that are going into remission right away. I mean, there are so many that do.
Yeah, and it's really important that people understand that not everybody's rheumatoid arthritis is the same. There's different whole bunch of different variations, mild, moderate, severe, when you're diagnosed, all sorts, socioeconomics. I can go on. But the thing is that even if they don't have a diagnosis of anxiety or depression, just a grief counseling or something can be so beneficial to somebody because a rheumatic disease is such a life-changing experience. And it's not even just like going to a psychiatrist or a therapist, it could be a social worker because social workers can not just help them with the mental health side, but resources and supports that they might need to help them live a healthier, better life with a rheumatic disease. Like if they need disability parking pass, they know how to help them get that. Or if they need to go on to disability, they can help them with the paperwork and things like that. And just how even that having that kind of support is really important for our mental health. But I think, yeah, that would be my biggest takeaway is that mental health support should be offered uh, to everybody who's diagnosed with a rheumatic disease. And not just at the beginning, but throughout, because it might at first be too overwhelming.
That's a really good point. I only have two other things to add. One is I have this little soapbox about anxiety as well as depression, because I don't tend to get depression, but I definitely have clinical anxiety, right? So a lot of times there's been a lot better awareness of depression in the role of people with chronic illnesses, but I think anxiety can kind of hide in plain sight, for lack of a better word, because anxiety can make someone almost like hyper functional, like kind of a perfectionist, like, oh, I'm just gonna like, I'm gonna, track my symptoms and I'm gonna do all this stuff. And yeah, yeah. So and you can have both. We can have anxiety and depression for sure. But 20% of people with rheumatoid arthritis have a doctor diagnosed anxiety disorder. 33% of people with psoriatic arthritis report at least mild anxiety. And the Arthritis Foundation did just a survey a couple years ago, and it said 66% of people with any form of arthritis reported anxiety or fear in the last 77 days, which again, yeah, you're like, who wasn't anxious or fearful? And people with ankylosing spondylitis are also more likely to have anxiety. So just know you're not alone if you're feeling anxious. And I wish that's one thing. I mean, I try to live my life with like regrets, but that's one thing I absolutely would have done earlier if I could do it again, is go to therapy earlier, get mental health support, whether that's a social worker, whether that's a counselor, whatever. I joke sometimes, I'm like, the best thing I could have done when I was pregnant was not take a birthing class, because it ended up being totally useless because I had to have a planned C-section, was trying to breech. I should have gone to like to therapy during that time, because it was much harder on my mind than my body transitioning to be a mom. But yeah.
Back to also the therapy and how to access it. And my key takeaway, because this has to do with yours before you jump onto your next one, is how they highlighted that occupational therapy is also a great way to get cognitive behavioral therapy, which is always brought up all the time for people when they're struggling with their mental health, being what I've seen the most beneficial treatment other than medications. So highlighting the importance of the multidisciplinary team and the importance of occupational therapists and how they help not just with the physical side of living with a rheumatic disease, but also the mental health side.
Yes. And the third wave, there's a therapy that I talk about a lot on this podcast called acceptance and commitment therapy, ACT. And acceptance is not a bad word in the case of ACT, and that's very evidence-based for chronic pain as well. And it's considered a third wave of cognitive behavior therapy, but it feels to me very different than traditional CBT. And that was the only other thing I would add to the mental health section is just that I don't think I had time to say this in the I can't remember if I did, but I had gotten some resources on the importance of, or the benefits of, support groups and support programs. Because I know both you and I are very passionate about that. And, there are many different, that is actually something that's very well studied, is the benefits of support programs, particularly ones facilitated by somebody with some degree of training in facilitating support groups. And there, again, things like kind of these open Facebook groups can be great, but a support program where you're actually in real time, whether it's in real life or online, interacting with other people with the same condition, are super, super beneficial to people's mental health as well as an adjunct to additional therapies and such. So,
and what they don't talk about is they say support groups are beneficial for the person going to them, but as a person who runs them, they're also very beneficial to me as a person who runs them. So that's because you're being, there's things like that you can do for your mental health that, you can't get that from a doctor.
100%. Well, in sleep, this was definitely Daniel's area to shine in terms of he provided a lot of resources on the prevalence of sleep disruption in rheumatic diseases across the board. What were some of your takeaways from this section?
So Daniel provided so much information. It's hard to narrow down what the main takeaway was, because on the resource guide, you can find articles. I made each researcher kind of type out what they wanted to say, and Daniel just went to town, and he basically wrote us a book on how to, understand sleep issues. But he described it so perfectly and talked about like the different issues. And I think the biggest takeaway that I've had, and this isn't my first time working with Daniel too. I partnered with him in 2019. Was when my first ACR. So I brought him back so that we could do another session. But the biggest takeaway is that sleep is not brought up enough, and it's often just brushed off as part of our disease. when there are things that we can do or have done to us to help us with our sleep. Like, what if we have sleep apnea and need a CPAP machine? So it's really important for rheumatologists to recommend their patients who are struggling with sleep to maybe go get a sleep assessment of some kind to diagnose any underlying sleep issues, because that is actually quite prevalent in people with rheumatic diseases. And even from my own experience, when I talked about sleep, I was kind of just told it was part of this, you know, the disease, and probably is. But there is a definite need to not just brushing off these symptoms and saying it's just part of the disease, learn to live with it. It's like, well, how do we learn to live with it? You have to help us with that. And like, do I need others to help me with that? So I think just my biggest takeaway was that even though we spoke 6 years ago at ACR about it, it's still not, being addressed enough. And then like when he also some estimates of the sleep disturbances or problems in people with rheumatic diseases was intense. Rheumatoid arthritis is up to 70%. Osteoarthritis is 80%. Fibromyalgia, 90%. I have all three of those. No wonder I suck at sleeping, which is weird because I try and practice it every day, multiple times sometimes. You'd think I'd be good at it.
No, but it's not that part of it's out of your control, right? And that's one of the biggest things I tell the people in the support, support program, and I teach in the self-paced course of Rheumatoid to Thrive is if you are feeling you're having inadequate sleep or you're feeling extremely fatigued, it's very, very important to rule out a sleep disorder because people with rheumatoid arthritis specifically are much higher risk of a sleep disorder, even if they have no other risk factors. So even if you're not overweight, you don't smoke, you don't snore, all those other things that can make you more likely to have apnea, just having rheumatoid arthritis makes you much more likely to have a sleep disorder. So if you have something like a sleep apnea that can actually be partially fixed with like a CPAP, that would be, you want to do that, right? You want to fix anything that can be fixed.
Yeah, but you can't get a CPAP machine unless you're being tested for the need of it.
Yeah, you have, yes,
So it's like
yes.
obvious, like if somebody complains about sleep, well, send them in for what they need to rule it out.
Exactly. And unfortunately, we have to, as you've heard, probably those listening have heard a million times, you do have to be your own best advocate often and kind of push for those things and push for those referrals because your doctor won't always give them. And the last thing, which is again a huge, huge, huge topic, is diet and nutrition. I know often sometimes people say the spaced symptoms with the D at the end would be like diet, but the information on diet, people can find it and the resources in the resource guides. But did you want to share any quick takeaway before we wrap it up?
Yeah, I really, the reason why I added diet or nutrition to this session is because it has so much to do with those extra-articular symptoms. Fatigue is greatly impacted by what we eat. When I eat, more of a Mediterranean style diet, which you can refer to the resource, there's tons of information on what that is. I feel better. I have less fatigue. I feel sharper. It helps with my cognitive function. It helps, fuel me for exercise. It helps with my mental health. And then also how our mental health can interfere with our diet. When we're depressed, we often have lots of habits that we need to break, which can include overeating or sometimes even undereating for some. And then I also wanted to talk about how nutrition can affect sleep because it can. When I know, like Christina, I've known for a long time. She's a rheumatic disease patient and registered dietitian, and I've asked her like things after my diagnosis. I've noticed how much more sensitive I am to food and how maybe different medications might interfere with things. So I've noticed things like if I eat pizza, I have a really bad sleep. Why is that? And she was able to explain that, and then it kind of makes me realize that what I put into my body when what I eat really does affect how I sleep. And it's really important for other patients and care providers to, tell us that, know that, because all of these different therapies or multidisciplinary team members can help us guide us through these symptoms.
Yeah. Yeah. And Christina's an amazing resource. We'll definitely put her links in the show notes. And the one big, huge takeaway from me from this section is Christina made a really, really beautiful point about the importance of discussing nutrition in a way that is very nurturing, talking about food in a like a potentially the positive benefits of food choices versus this shaming and scare tactic
Yeah.
method, which unfortunately is very prominent in social media circles, where they're like, did you cut out sugar? Did you do this? Did you do that? You can't eat that. That's inflammatory. You can't eat that. That's inflammatory. Well, technically what's inflammatory is going to be completely different for each person. Dairy is inflammatory for some people who are sensitive to dairy. It's completely not to others, and it's a great source of calcium to them. So she just, I'm not going to say it as beautifully as she did, but she just made the case for encouraging your patients to see nutrition as the positive benefits of nutritional choices rather than food phobia, because food phobias can turn into an eating disorder called orthorexia, which unfortunately I've seen many people have fallen into this, whether it's full eating disorder territory or just food fear territory, where they get so obsessive about eating clean and eating healthy that it actually becomes a disorder.
Yep.
Um, and that's a huge passion of mine, is helping people see, it's not a one size fits all. For some people, like for me particularly, there I have definitely certain food triggers that are more for like stomach pain and stomach bloating than necessarily directly joint pain and joint inflammation. But things like exercise make a big difference for me. Now, I have other friends with arthritis who they're the opposite. Exercise doesn't really have a huge noticeable effect for them, but nutrition does. So seeing your body as kind of like an experiment and being curious and open about it versus like dogmatic, like I must follow this one path, is going to be hugely in your benefit.
I think it's really important. That's also another reason why I brought up nutrition in the panel, because I remember when I was, first diagnosed, trying to find out how to eat healthy. It was so overwhelming. I didn't know where to go to. All the misinformation online, all the shame that we experience. I remember like standing there in my kitchen shortly after diagnosed, crying because I didn't know how to make a healthy meal that wasn't full of stuff that was going to make, I was so fearful of cancers and everything else. I was like, am I going to pass this on to my kid now? Like, just being so afraid because of like the information and the shame that I felt being diagnosed with an autoimmune condition, and how I'm not using diet to cure it, from some people and the misinformation, especially online. Um, I wanted to bring up, that the misinformation's there, and how, diet isn't going to cure us, but it will help us.
That's always an important caveat, that it can support, but it's definitely not going to, there's no evidence that diet alone can cure rheumatoid arthritis if it's actually rheumatoid arthritis. That's the problem. So
Yes, because it could have been something else like reactive arthritis
yeah,
or
exactly. Yeah. And so you have a ton of helpful resources. Arthritis Society has a role of nutrition and arthritis webinar on an anti-inflammatory arthritis friendly
so
eating.
many.
So many. So please go to, it's chroniceileen.com/it's not just joint pain, but it's also going to be linked in the show notes. And I'm just so grateful that involved me as a panelist in this discussion, because it was so gratifying. I will say, for the record, the room was pretty packed. There were a lot of rheumatologists there too. And there were rheumatology health professionals like occupational therapists and non-doctor um,
Mhm.
uh, people. And there were also patient advocates there. And
Yeah,
people were very engaged. And hopefully there'll be lots and lots more sessions on this in the future.
I hope so too.
Well, make sure to follow Chronic Eileen, and we'll catch up with you more later. Bye bye for
Thank
now.
you. Thank you. Bye bye.